So this morning's talk is on genitourinary tuberculosis. Tuberculosis is primarily a pulmonary infection. However, once the bacteria invade the lung, it does disseminate throughout the body and invades virtually every tissue in the body. And it does affect the kidneys and can lead to end organ damage in virtually all components of the genitourinary tract. This morning I've got a case that I encountered when I was at St. Paul's that I'd like to present, and following this I'd like to review the epidemiology, pathophysiology, and the medical and surgical treatment of tuberculosis. This case is a 41-year-old Asian male who presented with a 6-month history of lower urinary tract symptoms, specifically intermittent gross hematuria and quite severe nocturia. He did have a history of stones which were treated back in mainland China, and he had not had any over the last few years. Preliminary workup, including a urinalysis, showed red cells, white cells, and protein, and the culture came back negative for growth. He was initially seen and assessed over on Vancouver Island, where they carried out a CT scan in February of the last year. The CT scan demonstrated multiple dilated calyces with a few calculi in the interpole dilated calyces. In addition, the ureter was significantly thickened. So he was referred to St. Paul's with a presumptive diagnosis of calculi within calyceal diverticulum and a possible diagnosis of interstitial cystitis based on his symptoms of storage symptoms. He underwent a pyelogram which basically confirmed the non-contrast CT. There's multiple dilated calyces here on the right side, and the left side the collecting system appeared normal. His urine was sent for AFB and came back as positive, and eventually after 6 weeks he grew Mycobacterium tuberculosis. He was seen at the TB clinic and started on a 4-drug regimen. He underwent cystoscopy, I believe. I didn't have the report in the chart. Maybe you can recall.
I didn't see Distal I think it was somewhere on the island.
Yeah. There was a a similar picture.
Yeah. But I mean, that's when it shows plastic for something. And that was radioactive quick.
Mm-hmm.
You see the tip in your area and so forth, you would think the pathology so as long as you have.
Yeah.
It would be very suspicious to me to change that.
I think one of the differences would be that the calyces you can see here they're narrowed at the infundibuli, which is classic for TB.
Who's Barrett syndrome?
What's that? Okay. I'll look it up.
So were the smears positive for TB?
The smears are positive, yeah, from the urine. And they won't actually do a TB culture unless they see AFB in the urine.
Or if you give them a strong history.
Yeah, or a really good history. But if they cultured every request that came in, they would be overwhelmed with what they told me.
Convert generally is that compound positive smears in TB. I don't think that's universal finding at all.
No, it does represent a significant burden of disease.
But I think the point is that it's negative smear. I'm not sure that's a good policy if you have a high suspicion.
Yeah, well, that's what they told me, yeah. So I'll get back to the case later on, but I'd like to review first of all, the history of tuberculosis. This is a disease that's been around since the beginning of civilization, and in Campbell's they talk about looking at some of the bones from the mummies in Egypt, and they can see evidence of TB in these skeletons, and it's been called various things over time. Consumption, it was called phthisis by Hippocrates, and this is a term that describes a wasting condition associated with pallor and diarrhea. It's also been called scrofula, which is kind of a neat word, but this basically is the form of TB that affects the cervical lymph nodes, which separate through the neck. Also called the king's evil because it was felt at that time that you could be healed if you were touched by the king. During the Industrial Revolution in Great Britain, TB became endemic, and this was related to overcrowding. And ultimately, during this period of time, there was no treatment, and up to a quarter of deaths were due to tuberculosis. The cause of tuberculosis was identified by Robert Koch in 1882, and based on his work with TB, he came up with Koch's postulates, which form the basis for the study of infectious diseases even today. This is you may recognize this fellow is Armand Frappier, who's a famous Canadian researcher who's dedicated his life to understanding and treating tuberculosis, and he actually worked with the scientist who developed the BCG vaccine, and he called this la tueuse de mama because his whole family died from TB, and this means it's the mother killer. And I'm not sure what's going on here. I just found this on the internet. Maybe he's getting paid off for his years of work, but it's probably pretty late. Or maybe he's paying her. I don't know.
Thanks for a good time on the ball.
Yeah, we blanked that out. Yeah, he may have a little scrofula himself. Yeah. There's there's actually a BCG strain named after him. So funny. Okay. And the reason there's a BCG strain named after him, and a research institute named after him as well. Yeah. So on a global scale, TB is a major problem, and the World Health Organization estimates that close to a third of the population is infected with TB, and on an annual basis, there's around 8 million new cases detected, and somewhere between 1.5 million to 2.5 million people die each year from tuberculosis, which is a fair number of people considering there is treatment for this condition. Over the last 15 to 20 years, there's been a rise in drug-resistant tuberculosis, and I'll just briefly talk about why that is. This is a histogram showing that the TB is really not well controlled in Africa. You can see that it's gone up and up, and this is closely related to the epidemic of HIV. In the industrialized countries, we've seen a steady incidence of tuberculosis over the last 20 years. There was a bit of a blip in tuberculosis in the late or mid-'80s when HIV started to appear. The World Health Organization estimates, or this is an estimate of the mortality. You see that sort of in this around here when drugs were developed for TB, the mortality started to decline. However, since the mid-'80s, with the rise of HIV, the incidence or the mortality is on the rise once again. Some of the factors that contribute to this high mortality and high spread of this disease are the fact that the population of the world is growing. This is a contagious disease. Overcrowding tends to facilitate passing this from person to person. There's been a catalytic effect. Patients who are infected with HIV almost universally develop active tuberculosis, whereas in the general population, only about 5 to 10% of people infected with TB will actually ultimately develop the condition. Control programs have been a problem. Even in North America, there's been somewhat of a lackadaisical approach to controlling this condition and screening for it, especially in the mid-'80s, and this is when we started to see a rise of TB. Along with this, the development of drug resistance and really the lack of a political will to tackle this problem in the third world has all contributed to the rise of this disease. This is some data from Health Canada, and we can see that in 1926, tuberculosis accounted for 7% of all mortality, and then in 1990, all infectious diseases only accounted for 1%. And this really relates to the development of effective drugs. After World War II, isoniazid, ethambutol, streptomycin, these drugs were developed, and then really you can see that the mortality declined thereafter. Another graph just showing the incidence and mortality in Canada, and once again you can see that in the 50s the number of cases and the mortality declined, and it's remained stable since about the 70s. This is some data from British Columbia. We can see that on an annual basis in BC there's about 300 to 360 cases of tuberculosis. Out of all these cases, the great majority of these cases are in patients who are born outside of Canada. And when I spoke to the local expert, Kevin Elwood, he was telling me that 75% of the cases are imported from abroad. And roughly 5 to 10%, there's roughly about 5 to 6 cases of genitourinary tuberculosis on an annual basis in BC. You could break it down based on the region, and not surprisingly, the highest incidence is in Vancouver, where there's the highest concentration of immigrants. Other populations where the incidence is higher than the general population are in native communities.
Is that provincial rate high for Canada?
It is high for Canada. The highest rates of TB are in Vancouver, Toronto, and Montreal, where the highest number of immigrants from India and China reside. People who are at risk, obviously people who come from countries where it's endemic, specifically China and India, where there is, it's estimated that 75% of the world cases are in these two countries, as well as sub-Saharan Africa. Patients with HIV are particularly prone to developing active tuberculosis, and therefore they're prone to spreading it to other people. People that are at risk for developing active TB are those that are immunocompromised, specifically with AIDS or steroid medications and transplantation. It's a risk factor. Multi-drug resistance is on the rise, especially in areas where patients are poorly treated. In Western Russia, there's quite a high incidence of tuberculosis, and specifically multi-drug resistant tuberculosis. And the World Health Organization has developed a direct observation treatment protocol where they send volunteers out into communities and actually watch people take their pills on a daily basis. It doesn't sound like much fun, but they have to do it. TB and HIV, this is something that's really made a difference epidemiologically, is the rise of HIV in sub-Saharan Africa. And like I was saying, if you come in contact with tuberculosis and you have HIV, there's almost 100% chance that you will actually develop active tuberculosis. Whereas if you're a healthy person, there's only about a 5 to 10% lifetime risk of developing active tuberculosis. All HIV patients are therefore screened with the purified protein derivative of PPD, and if they are positive, they will be treated for tuberculosis.
Is it more difficult to treat the HIV patient with TB drugs?
I don't know.
University.
A lot of the antiretrovirals are hepatotoxic as well, and all the TB drugs are hepatotoxic, so you're right, it probably is tricky, but I didn't really get into that. Here's some information from the United States from 1999 that really shows that genitourinary tuberculosis, some people say it's the most common extrapulmonary manifestation of TB, but it isn't. Lymphatic disease is the most common site outside of the lungs. And in this series, GU-TB accounted for about 1% of all cases of TB. In the developing world, if you screen people who have tuberculosis, there's a much higher incidence of AFB positivity in the urine, and it's somewhere around 15 to 20%. So it's thought that GU-TB is a bigger problem on a global scale.
Jim, that primary GU-TB, that 1.2%, so if you take pulmonary TB, how many of them will have GU-TB? If you have pulmonary TB, how many will have GU-TB?
Well, it's hard to say. Because TB disseminates throughout the body, I think they would all probably have bacilli. Well, I think they would probably be, I think it's still quite rare. I don't know how many people have GU-TB and pulmonary TB.
Only 20% of them have only extrapulmonary disease identified, assuming that they have lung disease.
Well, the way, I'll get to the pathophysiology of TB, but it gains entry through the lungs and disseminates throughout the body. So it can remanifest either as reactivation in the lung or reactivation anywhere else in the body. So those 20% would be people who had an initial infection and then reactivated elsewhere. Mycobacterium tuberculosis is the culprit. It is one of a family of Mycobacterium bacteria, including Mycobacterium bovis, which we're familiar with because we use an attenuated strain of this called BCG to treat bladder cancer. There's a number of other mycobacteria, including avium and intracellularity, which are common pathogens in the immunocompromised population, such as HIV transplant patients, and then Mycobacterium leprae, the cause of leprosy. Interestingly, the only host for Mycobacterium tuberculosis is in humans, so there's no reservoir where some of these other Mycobacterium species reside in the soil or in cattle. Mycobacterium tuberculosis only resides in humans. When you look at the characteristics of this mycobacterium, it's not really something, if you read about it, you wouldn't think that it's particularly virulent or particularly damaging. It's this innocuous looking bug that doesn't really grow that fast. It's non-motile, non-spore forming. It requires oxygen to survive, and it takes about 15 to 20 hours for a generation time. And just to compare, E. coli generation time is 20 minutes. So when you go to culture this, it takes a long time, and you have to use special media. And the cultures usually take anywhere between 3 to 6 weeks. To describe the pathogenesis of tuberculosis, basically what happens is the bugs are transmitted from person to person via aerosolization. So in order to get infected with tuberculosis, you 95% of the time have to come in contact with somebody who's got active cavitating tuberculosis, and they have to cough in your face, you inhale the bacilli. Now, having said that, there are case reports of sexually transmitted bacilli, but these are quite rare. Once the bugs get into the body, they invade the macrophages in the lung, and they have a way of avoiding death inside of these macrophages, and they proliferate for a period of time, and eventually what happens is the body develops mounts a response to these bugs, and it's delayed. It takes about 3 weeks, and by that time the bugs have either spread throughout the body or they've caused local damage. And what happens is if the body contains these in the macrophages, they get the formation of what's called a granuloma. And these granulomas can either fibrose and calcify and remain dormant, or they can become caseating, which means they're producing purulent material, and there's ongoing infection, progressive destruction of tissue. So in most cases, these bugs get into the macrophages, they multiply, there's a cellular response, and the granuloma calcifies, and the bacteria remain dormant in these granulomas. And then what happens is, over time, somewhere between 5 to 10% of people, for whatever reason, the immune system loses its ability to control these bacilli, and they reactivate and they form caseating granulomas, which is the active form of tuberculosis, and this is what causes all the tissue destruction. When these bacteria are treated, this results in scarring and calcification, and this is what we see in patients with UTB. We treat them, and they end up with scars in the ureters, in the infundibuli of their calyces, and in the bladder and elsewhere. The life cycle of TB is well understood. There's bacteria that somebody coughs on you, they come in, just like I said, it invades the macrophage, and these innocuous-looking bugs are able to prevent the fusion of this lysosome with the phagosome, and therefore they evade the natural killing of superoxide free radicals. And then what happens is, over the period of about 0 to 3 weeks, these bugs multiply inside of the macrophages, they escape from the macrophages, get into the lymph nodes, into the bloodstream, and they disseminate throughout the body. And this is where they reside. They either go on to if there's no delayed type hypersensitivity, these bugs, once spread throughout the body, cause what's called miliary tuberculosis, which is basically tuberculosis disseminated throughout the body. There's been a lot of research looking at NRAMP, and this is a cationic channel which is involved in fusion of the lysosome and the phagosome, and there's been polymorphisms found in populations which are particularly susceptible to tuberculosis. So it just goes to show you that we're all not the same, and some people who have different variants of this gene are more susceptible to active TB than those of us with different polymorphisms. Once they're inside here, this is the formation of the granuloma. They're in the macrophage. The T helper cell comes in. This is exactly what it happens when we put BCG into somebody's bladder, and this is the effect that is thought to be responsible for killing immunopathic cells. The T helper cell makes the macrophage produce IL-2 and interferon gamma. There's an activation of the macrophage, and the bacteria are killed. And during this process, there's recruitment of fibroblasts and lymphocytes, and we get the formation of an epithelioid granuloma. And this is some histologic pictures here. This is a low-power view. This is a caseating granuloma. This caseating means active, means pus. There's ongoing production of IL-12, gamma interferon, and destruction of tissue. This is a multinucleated giant cell. How does TB present clinically? Well, classically, in the textbooks will tell you that it presents in men, more commonly the women. It presents in the ages of 20 to 40. Usually there's vague symptoms. TB can really present like anything, and so if you always have TB on your differential, you're never going to be wrong. And in Canada, you're probably never going to be right, but at least you won't be wrong because it's not very common. Genitourinary TB. These patients present with vague storage symptoms, nocturia frequency, just as our case did. And sterile pyuria is the classic finding on urinalysis. It's always on the exam. Acidic urine? Okay. Gross hematuria can also be a feature of presentation. To make the diagnosis, it's not that complicated. PPD test is something I'm going to talk about in a second. This is a test that demonstrates that you've been exposed to tuberculosis. And there's different ways of measuring this and grading this based on who you're testing. You need to send urine, AM urine, first morning urine, because that'll have the highest concentration of mycobacteria in it. And they take this and they stain it for using a special stain that exploits the particular characteristics of the cell wall of the mycobacterium. It's called the acid-fast bacilli, or the Zeal-Nielsen stain. The urine is then sent for TB culture, and there's also a PCR test which is available, but this is quite laborious and is not really used that often, at least in BC. All patients who you're screening for GU-TB should also do a chest X-ray, because depending on where the site of infection is in the genitourinary tract, there's a good chance that they will also have active disease in their lungs. The PPD test is a purified protein derivative. This is a extract of mycobacterium. It contains antigens, mycobacterial antigens. This is a test to demonstrate that you've been exposed to tuberculosis. It involves injecting this purified protein derivative underneath intradermally, and then waiting 48 hours and measuring the inflammatory reaction. So if you've been exposed to TB, and depending on your immunocompetent status, you'll have a reaction. So here we have 15 millimeter reaction, so this person's been exposed. If you haven't been exposed, then what you'll see is a little pinprick here at 48 hours.
Kevin, what percentage of the population is vaccinated? In other words, are medical students still vaccinated?
No. There's 30 years ago, all medical students were vaccinated, and in Canada, North America, we don't vaccinate routinely anymore, except in target populations where there's a high incidence of tuberculosis, such as in native communities. But in other places around the world, everybody's vaccinated, India and I think in China as well. And what's the BCG? I'll talk a little bit about the BCG vaccine. What it really does is prevent severe illness in children. So the PPD test, once you've injected this, you can measure the inflammatory reaction, and based on what risk category you fall into, this will determine whether it's a positive test or not. And basically, just to quickly look at this, those people who are immunocompromised or have a significant exposure will have a lower threshold for calling this a positive test. So as a resident, we fall into this category. As a hospital care workers, we fall into this category here. But if you've recently been in India working in a TB ward, you'd fall right into this category. Endoscopy doesn't really have much of a role in establishing the diagnosis, and actually biopsying bladder lesions that are tuberculosis is contraindicated, and this is written in bold in the textbook. But given that it's such a rare condition and that oftentimes we don't suspect this diagnosis, I don't know how you'd really prevent yourself from biopsying this, because some of the tuberculous ulcers in the bladder can look like carcinoma in situ. Ureteroscopy and retrograde pilography can also be useful in assessing the integrity and the functional status of the ureters in the bladder, because when these granulomas heal, they cause stricturing and fibrosis of virtually the whole collecting system.
I'd be kind of reluctant to ureteroscope on tuberculous ureteritis. When you find that, it's like dilating cement. I don't know, I think it's very tough to get your ureteroscope through that.
Yeah.
Retrograde pyelogram would probably show you the scars.
I don't know about ureteroscopy.
Yeah.
I think the only advantage of doing the biopsy is that you'll know in 40 hours that you got a caseating granuloma if you see something, and then you treat the guy. I'm not sure why that prohibition is in the book. I think it's a very fast way to get the diagnosis. If you're lucky and see some of your biopsy, then you know right away you have to wait for 12 weeks.
John, the reason that's there is the same reason they tell you not to put BCG in a bladder that's been recently biopsied. The incidence of miliary spread goes up significantly.
Yeah.
You've got good blood flow as long as you're on it, but you biopsy and send them out from the in the office for 6 weeks. I can well remember a couple of Chinese patients who got deathly ill in a big time hurry.
Surely if you treat them right away, as soon as there's no biopsy results would be
When Sam had them within less than 2 weeks, John, they were admitted with miliary TB, and we thought a couple of them were going to die. When they rescued them.
When did that? I can't remember. When did that?
I mean, they really got sick big time, and this was using BCG on bladder, supposedly attenuated MTB. That's what came from.
Something to keep in mind. The BCG vaccine, as Dr. Wright said, used to be used commonly in Canada. Because the prevalence of tuberculosis has dropped so low, it's no longer used. However, it is used in areas of the world where TB is endemic, such as India and China. It's an attenuated strain of Mycobacterium bovis, which was developed by researchers in France in the 1930s. And it offers variable protection, and the benefit is felt to be specifically in the pediatric age group, where it can prevent the severe tuberculosis from developing. And so children who are vaccinated within the first year of life in these countries do have some protection against Mycobacterium tuberculosis, and this protection does wane over time. So once adulthood has reached, the effect of the vaccine wears off. And as urologists, we're actually on our own vaccine program or campaign, because every time we put BCG in somebody's bladder, we're actually vaccinating them. So I thought that was what the tuberculosis expert here was telling me, and he thought that was kind of funny that we were vaccinating people without knowing it. But tuberculosis, starting at kidneys. As we discussed, the tuberculi disseminate and remain dormant in the kidneys, and then because of a drop in the immune system, the TB becomes reactivated and forms caseating granulomas. Caseation involves destruction of tissue, and when these caseating granulomas heal, they become fibrosed, and they can lead to a number of problems. Caseation can cause papillary sloughing and fibrosis of the renal pelvis and the ureter. This is a CT of early tuberculosis, and what it really looks like is a lobar nephronia. There's some increasing of the parenchyma here, hypoperfusion. This is a contrast CT, and what you see is a wedge-shaped hypoperfused segment, and this would be difficult, at least for me, to differentiate between that and a straightforward bacterial pyelonephritis. So these are the early signs radiologically. So maybe you want to make a comment, or maybe for you that would be easy to diagnose with. Yeah.
bile and bacterial pylori are different than that. Distinguishable at this stage. So you have calcification and parking system stricture with the segmental ramification failure to do that sort of thing. You really can't tell whether it's
Yeah. So later on, things start looking like this, and then you may be more suspicious, exactly like Dr. Zurich is describing. This again, a contrast CT, and what I think we're seeing here is scarring at the infundibuli and then proximal dilation of these calyces. And this is more classic of tuberculosis.
Is there a difference of that? Probably the most common thing that we would see that is somebody with some segmental dilatation.
Yeah. Later on, you can get what's called the putty kidney, and this is a non-contrast film. This is the right kidney, and what the putty kidney is a kidney that's been destroyed by tuberculosis. There's been diffuse caseating granulomas which have healed and become fibrosed, and you get this big calcified wad of debris in the kidney, and that's called the putty kidney. It doesn't respond well to medical treatment, as you can imagine. The adrenals can also be affected, and at one time this was a common cause of Addison's. And what you see radiologically are calcifications in the area of the adrenal. And here's some pictures of pathologically what you're dealing with. Now, although the bacilli implant in the cortex, they seem to favor growth in the infundibular areas. I'm not quite sure why that is, but this leads to, again, granuloma formation and fibrosis and stricturing. This is a pathologic section of a putty kidney, and this is all just necrotic debris that's been calcified, and you can see that the parenchyma of the kidney's been thinned out to just a few millimeters of parenchyma.
Does it need to be operated on?
Yes, it does. Well, that's what the evidence would suggest, that within these non-functioning calcified autonephrectomized kidneys, there can be dormant bacilli which don't get treated by the bugs because there's no perfusion to these areas, and they can lead to problems down the road, and I'll get to that. TB can also lead to acute renal failure. It can cause glomerulonephritis and amyloidosis, which leads to renal failure. And in some parts of the world, this is common. In Greece, somewhere around 5% of patients on dialysis are on dialysis as a result of having TB glomerulonephritis. TB affects everything downstream from the kidneys as well, including the ureter, the bladder, the urethra, and we'll talk about those in a systematic fashion. When you look at the ureter, typically the disease starts in the distal third of the ureter, particularly at the ureterovesical junction. What we see early on are these ulcerations, bullous edema, and this eventually progresses to, again, fibrosis, scarring, and the appearance of these gulf hole orifices. And Dr. Maston was talking about the delta sign, which I didn't come across, but I think this is what the delta sign is this area of inflammation around the UO, which is classic for tuberculosis. Okay. The urethra can also be affected, although it's much rarer. It can be either an acute or a chronic presentation. In acute, it looks exactly like a sexually transmitted diseases. Purulent discharge. Chronically, again, leads to fibrosis and obstruction and scarring. Looking at the genital TB, the epididymis is probably the most commonly affected of the lower urinary tract genital organs. Testicle is very rarely affected, and the prostate and seminal vessels can also be affected. TB of the epididymis presents classically again in the 20 to 40 age group, and it can present again like a mass. It can present as an inflamed scrotum by a discharging sinus, or there is a high risk of infertility with infection in the epididymis and in the vas due to, again, scarring and obstruction of the vas. Most patients who do have TB of the epididymis are usually diagnosed on pathologic exam because the urine doesn't usually grow TB, and there's usually not an AFB in that, so usually these specimens are diagnosed in pathology. It's not quite understood how the TB gets there, but it's thought to be via the blood supply because the globus minor of the epididymis is most commonly affected and has the highest blood flow. when you're looking at a mass in the scrotum, the differential always includes a malignancy, and because we're dealing with men in the 20 or 40 age group, there's always a risk that it could be a sexually transmitted disease. So in areas where it's an endemic, physicians will treat this initially with antibiotics against gonococcus and chlamydia, and if it doesn't respond, then they switch over to anti-tubercular treatment, and then if this doesn't respond after 3 weeks, then they carry out an inguinal exploration, presuming that it's a malignancy. This is a picture of a fellow who's from Sierra Leone who presented with a scrotal mass, and when he was examined, they found significant inguinal adenopathy, and the CT shows this big collection of pus extending up into his, under his iliacus muscle. And because a high percentage of these patients are affected in their pulmonary region, he had a CT of his chest which showed significant mediastinal involvement. Tuberculosis of the testis and the prostate, like I said, the involvement of the testicle is quite rare, and it's usually secondary to an infection in the epididymis, with direct spread into the testicle. The prostate can also be affected, and it, again, is more rare than TB of the epididymis. When it presents in the penis or in the perineum, it can lead to the watering can penis, because the caseating granuloma basically erode through the urethra to the skin, and you end up with multiple sinus tracts in a watering can.
It actually looks almost like the point when you see it, same kind of thing. So that's something that you did see.
Mm-hmm. Yeah.
The other thing is that you didn't mention, especially about the genitals, those are all cold. By that I mean the beating on the vas and the epididymis and so on. They're never hot. They're all cold, and they're findings of induration, not of what we think of as acute inflammation. When you look in the prostate, instead of collapsing in, it's scarred, and we try to get out. It's like driving through a great cavern. It's one of the few things you'll ever see with an endoscope that something's clearly wrong. You've never seen a prostate even in a 20-year-old like that.
Yeah. That's a good point, yeah.
And when you were talking about treating tuberculosis enteritis with drugs for 3 weeks, what is the natural history on it? I never treated one. I mean, take them all out.
No, what I was talking about was in areas where TB is endemic and sexually transmitted diseases are endemic, somebody comes in with a scrotal mass. It's difficult to diagnose TB, and it may be, an STD, so they treat them with antibiotics.
But what's the expected response? What's the natural history of this tuberculosis after they might treat it medically? I don't know. What happens?
I don't know either.
They're not treating it for tuberculosis. They're treating it for...
Yeah, but then they switch over if they don't respond. If they don't respond.
So you said they switch then to tuberculosis drugs for 3 weeks.
Well, they must work if they're doing it. I mean,
If it responds, then they keep the patient on it for 6 months.
Yeah, they would treat it. Yeah.
It responds in 3 to 6 weeks. I operated on a patient with a hydrazide 6 weeks ago who was TB and who had positive sputum, and currently me, along with everybody else, is being tested close to that. I'm not going to go near you to this way.
High risk. So in the days gone by, patients with TB were sent to these things called sanatoriums, and this is one from... It looks pretty nice, actually. I was thinking of checking in there for a few weeks.
That's how our test is placed on the water.
Yeah, so this this place was called... Yeah. Have you been there? Right. They got some gardens here, and this is where they send the people, and they would just sit around the garden, and what they would do is lie out in the sun, because it was thought that lying in the sun was a way of treating this. And you can't read this one here, but it says bed rest and fresh air were important, and they got all these people lined up underneath this, looks like a concrete bunker. There you go. And then this is somebody praying because this didn't work and that didn't work. And then as a last-ditch effort, they call in one of the thoracic surgeons, and he gives you a pneumothorax, and that's supposed to help. None of this is done anymore because of drugs, and these are the drugs, and this is the current protocol that we give. So patients are treated for 6 to 9 months after you diagnose them. These are the 3 main drugs that are given initially. Prednisone is also indicated and is thought to help with some of the inflammation that can occur in the ureter with the acute caseating granulomas. INH is, these are interesting drugs, specifically when you're writing the AUA in-service exam. There's always at least 2 or 3 questions on this, so I thought I'd go over them. This is what they look like. They're white pills. They're bactericidal. Hepatitis, they all cause liver dysfunction. And one of the characteristic side effects of INH is peripheral neuropathy, so you have to supplement them with pyridoxine. Rifampin is another interesting drug, hepatotoxic, gives you flu-like symptoms, and this is one that you have to keep an eye on other drugs because there's interactions with over 100 other drugs, specifically steroids and anti-rejection drugs. And it can actually, it's a P450 inducer, so it can drop the levels of these drugs and cause rejection in transplant patients. I don't know, have you treated anybody particularly with, have you seen this interaction in your transplant population?
Yeah, it's extremely high level of
So you have to triple the drugs. So it's a real thing, yeah.
So Bill, have you seen patients, transplant patients with TB?
I think you treated.
Have you ever diagnosed or anybody with TB in the transplant?
Usually it's picked up nowadays. It's picked up in it, so they're treated.
They get screamed at PPD, right?
And then what we do is, if they've been treated or we're not sure how they've been treated, but they're not sick and they got a history of TB, they say they were treated. They get the transplant and they get 6 months of INH alone.
Yeah.
But if for some reason there's a reactivation or something up there and they end up on more than one drug, for example, that's going to be a problem.
Yeah. There's a list of some of the other drugs. Again, they all have characteristic side effects. This is an aminoglycoside, and like all the other ones, it's nephrotoxic, ototoxic. Ethambutol can cause problems with your vision.
What are the 3 first-line drugs?
The 3 first-line, I don't know if you can read this, but for GUTB, rifampin, isoniazid, pyrazinamide are recommended for 2 months every day, followed by a 4-month course of rifampin and isoniazid.
So pyrazinamide, not ethambutol?
No, ethambutol is only for drug-resistant TB.
Where's cyclosporine over?
I think it's also used for drugs. It's not really on the radar screen as far as I can tell anymore. The main ones are.
It's the only bactericidal one that.
No, they're all bactericidal except for one of them is bacteriostatic. I think it's streptomycin. Yeah, ethambutol is bacteriostatic. All the rest of them are bactericidal. This is bacteriostatic. And the treatment, the length of treatment is controversial as well. And in Campbell's, they don't actually say what treatment. They just say there's various regimens out there. When I spoke to the guy in BC, he said they tend to treat all GUTB with 9 months for no good reason. And the previous edition of Campbell's, there was a guy named Gal who had a series of 300. He said you could treat them all with 4 months. But he had 1 failure, and that's not been accepted. And I think people are now treating with 6 months.
Well, before Gal, there was a guy called Latimer.
6 months, yeah.
Just treated it too, didn't he?
Yeah.
That's at Columbia.
John Latimer from Columbia. He was before Carlos.
He never really operated. He took out a lot of kidney. Like you said, inside for the organ.
Yeah.
But he followed for 20+ years, and nothing happened.
Well, there's not a lot of literature out on TB unless you speak Russian, but there is.
Kevin, before you go there, just so you do it, what Zeke is saying, having been under Latimer, and around here with Harry Cooper, we were all taught that you don't have to operate on those type kidneys unless they're obstructed with or secondary bacterial infection. And to to my knowledge, none of them ever occurred. Harry had a whole pile of them that followed, and there's still some that following them, as against the old days where they took them out and brought the ureter out to the skin. I'd be interested now if there's anybody in the Western world operating.
Yeah. Well, here's a series from Gal from 1980, because he's from England, yeah. It's not common in the United States or obviously North America, so we don't really have big series out there. Seems to be a lot of articles written in Russian. There's actually a Russian journal of TB. Maybe Vladdy's published in there. I don't know. Basically, he looked at 300 cases, and he looked at those with non-functioning units, and some of those who didn't have, 4 of them didn't have surgery, and 3 out of 4 of them developed abscesses, sinuses, and hypertension. So he suggests that you would want to take these out and maybe not observe them. And then there's other papers that have looked at taking them out and culturing them, and they find mycobacteria inside of these non-functioning calcified kidneys. Partial nephrectomy is also listed as an option, but I think, like you said, you want to avoid operating on these patients because they're probably difficult cases to do. But in Campbell's they talk about these calcified lesions, which represent calcified granulomas, and you have to keep an eye on them because they can expand over time. And these type of calcified lesions that what they say fail intensive 6-week treatment, and it doesn't really go into detail on what that means, would be candidates for partial nephrectomy. And obviously, if the calcification is increasing in size, this would suggest that there's a focus of infection that's not being appropriately treated with antibiotics and should be resected.
John, I mean, it's not uncommon for us to see calcified cortical segments in patients from India and Southeast Asia. I mean, I hate to see somebody start to say that this is partial nephrectomy.
I don't think it's unusual to see calcification, but mass-like calcification is characteristic of unusual. Obviously, the functional granulomas, so the solid field granulomas, so the confidence that especially big granulomas and calcification is pretty common.
Well, it depends what you call big. Once they start talking partial nephrectomy, I mean, it's one calyx bounced off and an asymptomatic patient.
We tend to defer to you guys when we hear what it looks like.
What are you going to do here? No, not one to start off with. So,
Having a really advanced stage renal TB where you before have either broad kidney or the classic
yeah.
It's around. I mean, Brian's got a tight kidney right now that we looked at last week, and I had the hydrazide that was unsuspected and got sunlight. But the majority of those, if they get secondary bacterial infection or stillness, that's fine. Because as Dick said, Harry used to treat it, and I don't ever remember a patient getting in trouble to not treat them, but in the patients who came down, particularly when they came here, when they came from the north, which is where most of them came in the native population, we used to operate on, had to bring the ureter to the skin unless you were going to take it all the way out. But man, they make dental granuloma as solid price, but you don't go there unless you really got a good reason to go.
Okay.
What if they're symptomatic, moderate?
Yeah, but that's not uncommon. If you talk to the TB guys, they'll take those patients away from you, and they will treat them, and they'll call you for the problem.
Yeah.
And otherwise, they suggest
So that's really the key when you're dealing with strictures, is to bypass the stricture with a stent, treat them medically, and then assess the damage later on. And that is really just what I've outlined in these slides here. You've got to treat them medically. Steroids may be useful. Stenting is important, treating them medically, and then coming back later on and assessing how much fibrosis there is and how extensive the stricturing is.
You're not serious advocating of data since they do. Give me a break, Kevin. What are you doing?
Yeah. Well, that's what the book says. So the book's got to be true. Yeah. So I'm just going to flip through a lot of these.
Published that paper, David and David? 1918.
Wow.
Still here in the book. It didn't work that either.
People still do it. Dilation, serial dilation is not effective. The strictures tend to recur. Bladder augmentation can also be an option in patients with fibrosed, low capacity bladders. I'm just zipping through this because I want to get back to the case. So our case, the patient has now been treated for over 6 months and has ongoing severe frequency, 15 to 25 times per day. And no stent. He didn't have any dilated renal pelvis. No hydro.
There were some parts of blocking system which were dilated, other parts of the system that was stuff that he didn't have, and there was some obstruction that it looked like more stenosis.
Yeah.
On that CT, I thought
well,
ureter going down out of that kidney.
This is what he looks like now. This is what the kidney looks like now. Contrast film. So the multiple dilated calyces with what appears to be infundibular cells. I don't know what you think. Yeah, I don't have all the cuts here. This is kind of every second cut, but this is post-treatment. Yeah, and on the delayed film, there's not much excretion of contrast from that side. So this is where we're at with him now. And, well, like I say, he's avoiding, yeah. He's on herbs, trying herbs right now. Yeah. So he'll be totally, like, anticoagulated now.
But it will always stay small. And the kidney, if it's asymptomatic and culture-free, and the TB guys are happy with it, tend not to be a problem, but there's no question that a contracted bladder is really annoying.
And one bit about surgery which you'll never do, but if you ever have to do it, the mistake we used to make was to use absorbable, non-absorbable treatment. So if you use silk, Dexon, or choline, or anything in a TB kidney, your abscess occurs on that. So one of the few times they will tie off the renal vessels with heavy stone. And it'll just downstairs. That's one thing. It's scary, but it's the only thing that works, because I've seen, I'm not as old as Jamie, but I've seen when I was 10 years old in Baltimore, I saw abscesses coming up. And then one thing my boss back then, Dr. Scott, said, you use stuff. Nothing else is from it. From it, you have to use stuff. You know what the guy used.
Oh, use stuff.
That's not silly. But
You don't see it anymore, but usually, back in the days we were doing those nephrectomies, it was always double IJs with number 1 chromic. It was never done with that.
Wow.
CBS?
And the other thing is, if you did a nephrectomy and you weren't going to take the ureter, you brought the ureter up to the skin and stitched it to the skin so it could drain, because if you tied it off down inside, you'd get infection inside that ureter from the stricture distally and from your time, and you'd be back trying to operate on it again.
Yeah.
You've got to be rather old and brave in this thing.
So just to summarize quickly, the TB is very rare, so you have to have a high index of suspicion. It can manifest as really many different things. So you always should have it on your differential. And then before you consider surgery, medical treatment is the way to go.
Excellent.